So Dr. Rahman, who was the Director of Advanced Cardiac Imaging at the hospital, Director of Non-Invasive Cardiology, is going to present tonight on PET scan and SPECT scan for cardiology. He has a residency at University of South Carolina in preventive cardiology at Brown University in Rhode Island, a fellowship in cardiology at Rutgers in New Jersey, and advanced cardiac imaging in Mount Sinai. He has a number of board certifications, and this talk in particular has been something requested by a number of people who wanted to hear about what he was doing. So I'm going to load his presentation, and then he will take us through it. Go ahead, Dr. Rahman.
Can you hear me?
I can hear you now. Go ahead.
Okay, perfect. Good evening, and thank you for the introduction. First, I'd like to thank each and every one of you for invitation for this talk. I'm going to try to keep things simple. As you know, there are many causes of chest pain and cardiac symptoms. Epicardial coronary artery disease is one of them, but majority caused by small vessel disease, inoca, minoca, and microvascular dysfunction. And PET-CT can diagnose all three causes of chest pain, including epicardial disease and small vessel disease. Next slide, please. I cannot move the slide. Okay, thank you. PET myocardial perfusion allowed to perform myocardial perfusion along with myocardial blood flow reserve, viability study to look for dead tissue versus hibernating myocardium, for diagnosis of inflammatory cardiomyopathy like in cardiac sarcoidosis, also for diagnosis and therapy response in endocarditis or graft infection. Right now in Gibson Center, we are able to perform myocardial perfusion imaging with myocardial blood flows, viability studies, and plan is for sarcoid. We are going to start in a couple of months after we trained our tech and staff. And by the end of this year, hopefully we are able to perform studies for endocarditis. Next slide, please. So this is what we do. We do scout images to identify where the heart is, transmission for attenuation correction with non-contrast gated CT, and the PET emission scan, which is a perfusion images. And then we fuse transmission and emission images. So basically, we eliminate subdiaphragmatic, diaphragmatic, breast tissue, and all other soft tissue attenuation artifacts. Next slide, please. So I think this is what it shows that, how much radiation dose we give with PET CT. As you can see with PET, maximum dose we give 2 to 3 millisieverts as compared to SPECT, depending on protocol, 10 to 24 millisieverts. And in contrast to cardiac cath, diagnostic is only 7 millisieverts. So every time we do nuclear SPECT, we are giving more radiation as compared to cath, and with PET, very minimal radiation. Can we go next slide, please? Another slide. Next slide, please. Yes. So if you look at the sensitivity and specificity and compared with PET and SPECT, we can see PET CT sensitivity and specificity is somewhere 90% as compared to sensitivity and specificity of SPECT scan, which is around 70%. Can we go next slide, please? So this is a newer trial which shows the similar results, 70% for SPECT and 90% for PET sensitivity and specificity. In Lamberton, in our hospital and also in our cardiology clinic, our SPECT scan is without CT attenuation correction. So sensitivity and specificity for SPECT scan is much lower than 70%. Next slide, please. So indication for PET CT myocardial perfusion imaging is similar what we have for nuclear stress images requiring pharmacological stress test. But in PET CT is recommended in patient with high BMI, high risk, patient with complex diseases, and especially in young patients with history of prior coronary artery disease or stent. PET-CT is preferred or recommended because these patients might be having repeated radiological procedure, whether it is nuclear or coronary angiogram. It helps decrease the lifetime radiation doses. Can we, next slide, please? So few word about myocardial blood flow. We are able to obtain myocardial blood flow with every study and rule out extensive epicardial disease beyond normal perfusion. Here we can see global myocardial blood flow. You can see in the last global 2.29. So there is no evidence of microvascular disease. Global myocardial blood flow normal is 2 and above. And if we look at the regional myocardial blood flow in LAD, left circumflex, and RCF, top box, we can see the LAD and circumflex territory, blood flows are pretty normal, but in RCA territory is low, which is correlate with the perfusion defect in RCA territory, as you can see in top line. So this is a very powerful tool. It's not only confirm the perfusion defects are real, but it can also tell us if the disease is more extensive than just a single coronary artery territory. So next slide, please. I think there's another slide should be there, which, no, go back.
So one of the slides that we removed for time was just the advantages of PET. Can you go through quickly the advantages of using this technique?
All
You
right, so
alluded to some of them.
don't worry. Okay. So this is not only basically myocardial blood flow, perfusion defect, but it can also tell us is there any other incidental findings. For example, on the first is hiatal hernia, pulmonary nodules or masses, pulmonary etiologies. We can see breast mass. This is the top left, bottom left, sorry. You can see breast mass, gallstones, and also we can see thoracic aortic aneurysm, calcification, or pericardial diseases. Next slide.
Okay.
This is also can tell us coronary calcification. The first slide shows there is no calcification. Second slide shows mild calcification, moderate calcification, and severe calcification. And we know based on calcium burden on coronary artery, treatment recommendations changes. Can you change the next slide, please? Yes, so if you have no calcium, just lifestyle modification. If you have mild calcification, a moderate statin can consider. And if you have moderate to severe calcification, aspirin can be added to moderate statin or high intensity statin therapy. Can you go to the next slide, please? So this is the quality of the images. As you can see, cardiac SPECT MPI with BMI of 28. We did SPECT and we can see the image quality. Difficult to distinguish between real defect versus artifact compared to PET. You can see on the right side, patient with BMI of 49 without any artifact, crisp images. Next slide, please. So most places only perfusion images plus minus calcium scoring perform, and in only academic center and big centers able to perform myocardial blood flow reserve. And very few centers in America able to perform functional flow reserves. Here in Lumberton, we are able to perform myocardial perfusion imaging, myocardial blood flow reserve, calcium burden, and also PET FFR. So we are doing everything, and only few places in America able to perform all four in PET CT, for PET CT myocardial perfusion imaging. Next slide, please. This is a sample report. As you can see, for SPECT MPI, there are only few data points, perfusion defect present or not, and EKG changes and LVEF. Remind you, LVEF assessment in SPECT scan, regular nuclear stress test, is a resting LVEF because we took images 40 minutes after doing stress. So these are the resting LVEF. And in PET-CT, we can get at least 15 to 20 data points. First, is there any EKG changes or not? Calcium burden on coronary arteries. Perfusion abnormalities, either reversible or fixed, present or not. Resting and stress LVEF, and resting and stress wall motion, cardiac output, stroke volume, transient ischemic dilation, any wall motion abnormality, all can be assessed with PET-CT. Myocardial blood flow results, any evidence of myocardial microvascular dysfunction, also tells us if patient responded to vasodilator stress or not. Uh, Also, we can see incidental findings. So a lot of information for primary provider and for interventional cardiologist. For pre-procedure planning, that reduce not only fluoro time and radiation, but also contrast quantity. Next slide, please. As you can see in this slide, we are leader in PET-CT, reading in North Carolina over the past 6 months. And if we correlate with left heart catheterization, we have 100% test positive predicted value and 100% negative predicted test results so far. Thank you. This is all I have.
Okay, thank you very much, Dr. Rahman. Dr. McLeod, I'd like to get your input and how you've seen it with your patients and your experience in having this test performed.
Yeah, I've probably ordered as many of these things as most folks have, maybe more. I'm amazed at the results. I'm amazed at the quality, the degree of information that it gives us, the focal areas of ischemia, the just the wealth of information that is there. And normal stress testing is sort of a blunt instrument to detect only ischemia. This characterizes calcifications that are not leading to ischemia. It also characterizes microcalcifications that are creating ischemia that is not detectable on any other kind of scan. So I'm just a big fan of it. I think it's a wonderful test. Did I get any of that wrong, Dr. Rahman?
Absolutely right. Absolutely. And the thing is, if we look at the sensitivity and specificity, it is the best stress test we have. Better than MRI stress test, better than nuclear, better than any type of stress test. This is the best to look not only for epicardial coronary artery disease, but also to look for small vessel disease.
All right, thank you. Are there any additional questions? Dr. McLeod, has it changed, I guess, your stratification of your patients and who you ordering this on?
It does. It obviously indicates who we've got to be extremely aggressive with, and sometimes who we can reassure and say, look, this is not coronary artery disease. You're great. And so we don't have to treat them aggressively in some other areas because we have reassurance. It's just a wealth of information. It really is.